Hi, good evening to everyone. Thank you for joining me for what should be another one of those very, very interesting discussions. This time with Dr. Claire Craig. Now, I have been following her for quite a while, and it's only coincidental that I came across someone who actually got me connected to her because I've wanted to talk to her for a long time. She was very outspoken in the pandemic. She was part of a group that was challenging the science. Those people are so rare that it's wonderful to hear their story, hear their journey, hear their thoughts, and learn from it. Because one thing is for certain, history shows us that those people who make a stand are very often those that we can learn the most from. So, without any further ado, let's add Claire to the conversation. Claire, do you mind just giving an introduction of yourself so that everyone knows who you are?
Sure, thanks very much, Philip. So I'm Dr. Claire Craig. I'm a pathologist, a diagnostic pathologist. I'm also co-chair of the Heart Group, which was set up in 2021. So we're a group of professionals who are multidisciplinary, and we have all sort of raised concerns around how the science was being twisted during the COVID years and since, to do with sort of, where health policies cause harm, essentially. Yes, and I'm, an author. I will call myself an author now as well. That's me.
Wonderful. Listen, when we think about where we are now, it's useful to get an understanding of the people who did make very unusual stances in the pandemic. So I just like to understand when you entered medicine many years ago. I mean, you're very young, clearly, so this couldn't have been that long ago. Um, but when you entered medicine, was that something you always wanted to do?
I'm 50, Philip. I just had my birthday. So
Oh,
um, I did. My dad was a medic, and his dad was a medic, and his dad was a medic, and I have a big brother who didn't do medicine, and so that my dad was really keen for me to do it, and I rebelled a little bit briefly, saying I wanted to be an engineer because I loved physics. That was my thing. I loved physics and maths, and he taught me out of it. And I went into medicine because I was hoping it would be more freeing. I think there's a lot of choice in what you can do with a medical degree. There's a lot of different options and how you use that. And obviously it's with relationships and people, which is something that I totally value, whereas engineering can feel a bit cold, I think, sometimes. So yeah, apart from that tiny little blip of a sort of year or two of thinking I might go another direction, I wanted to since I was I was 6 years old or something.
wow. And so then when you made the transition into pathology, what made you do that?
I was one of those people that was actually quite negative in medical school. So I was surrounded by the optimists who, every time they'd sort of tried a different specialty and was learning a different thing, they would want to do it, and they'd just be like swamped with choice and not know how to decide between them. And I'd always find a reason to not want to do each one. Um, but apart from that, fundamentally I'm a scientist, and I wanted to be true to that. And pathology is the most scientific of the disciplines within medicine. You cover the full breadth of things, but you're doing it from the perspective of the evidence. And also I was always a little bit cynical around pharmaceutical products and the evidence base that they were based on, and I didn't want to become somebody selling something that I wasn't 100% sure about. And diagnostics is the way to avoid getting into that kind of trap. And I think diagnosis is hugely, hugely important. I think it's undervalued, but if you can't get the diagnosis right, then you're onto the wrong track from the beginning.
One of the things that I usually say is that the foundation of Western medicine is pathology. We Everything we do is based around that understanding and that grasp of the science around it. Why is it that it seems that we have drifted away from that in the past probably 2 decades?
Yeah, I mean, there's a lot of reasons for that, I think, aren't there? So, I think pathology gives you, the kind of grounding for where things are, and it all ultimately comes from it's a way of auditing medical work, and the ultimate audit is to be doing postmortems, because if you've got a situation where you think you've understood what's gone on, you think you've done the best treatment, and somebody dies, then the postmortem is the way to look properly and thoroughly and see if anything was missed or misinterpreted. And that allows feedback that allows doctors to keep learning, because we're not all perfect, and there's always improvements to be made. But the culture around doing postmortems changed hugely in the last few decades, such that there are two ways postmortems are done. They're either done because the coroner requests one as a legal requirement, because there's something around the death that might be suspicious and need investigating, or the doctors who are caring for the patient can request one with consent of family in order to investigate, even when when someone died broadly, but you just want to make sure that you've got the full picture. And I don't know if you remember the Alderhay scandal back in the 90s, where pathologists had been keeping whole organs of children without the family knowing. So they were literally brains in buckets of children who had died, and the family thought they had buried them completely, and they hadn't. And that obviously caused immense hurt and pain, and people did not want that to ever happen again. And the response to that possibly made the pendulum swing too far the other way. And so everybody became very, very cautious about doing any kind of postmortem, as if the families would be upset by the investigation. And there's often a lack of communication between pathologists and the families anyway, because we're hidden away in the labs, and we sort of become the doctors who are caring for the deceased tend to be the intermediaries in that conversation. And those doctors themselves are not necessarily the best people to explain what the benefits of doing a postmortem are, because even medical students are not that exposed to them anymore. The whole thing becomes a vicious cycle. We do fewer, they see fewer. The whole kind of reason behind doing it decreases. They don't sell it so well to the relatives, and then the relatives don't ask for it. Although actually I've seen plenty of situations where relatives want them and they can't sort of get them, because the culture is such that people aren't keen on doing them anymore. And they do take up a lot, they do take up time and the resources, and we don't always have that either.
So one of the things that I'm interested in, and hearing your objective opinion on it, is that early in the pandemic, as we come now to the pandemic questions, there was this question about pathologists not doing autopsies because of the risk to pathologists. Okay, they would then become exposed. Now, I mean, we were frontline. We had to see patients who definitely had COVID. You needed a BSL-3 level lab to do autopsies. Was that a fair decision at that time, when we needed to understand what was going on?
Well, I don't think it was a brilliant decision, but to be fair, that story that the pathologists stopped doing it was not universal. So there were absolutely departments and hospitals where all the pathologists refused to do them, but there were other pathologists who were doing them. And the Royal College of Pathologists collated a sort of a case series, and published the series to show the overlaps in pathology and to try and understand it better. It was only 40, it wasn't huge. But nevertheless, I think there were pathologists who were doing them. And the fact that there were pathologists doing them shows they could have been done, right? And, I mean, I do remember the immense fear that there was at that time. There was huge fear. But I think your point is right, that pathologists are frontline doctors too. And, the pathologists are the ones that should understand better than anyone the risk of a respiratory infection in a healthy person. And I think there was just so much kind of extreme things being said about this illness, and the videos from China of people collapsing dead in the street, which I fell for too. I'm not, I was not immune to that. Embarrassingly enough.
I'm glad you mentioned that, because I was just looking for that recently. I wanted to find those videos again, because we now know that absolutely that was misinformation. Patients do not die collapsing in the street with COVID. It's just not how they die. And so who created that stuff? And who is responsible for putting that out and putting the fear of God in all of the population? I really need to find them. But you remember it as well.
I do remember it. And that, I think there are two answers to that who created it question. So on the one hand, I think, they were coming out of China, and I think the CCP was very likely involved in some of them. But there's also the question of, there was some, Wuhan already had, prior to any of this, quite an activist community who had been very vocal about chemicals in the water supply. And they felt that the government had been, they had been failing them and had exposed them to harmful things. So there was a sort of population who were quite well educated about that in the lead up to all of this. And so when this comes along, I think these activists, they're attacking us again, that here they are again, and we're the guinea pigs again. And so some of the videos may have been hyping it up because they were trying to get that sort of activism going. I mean, I don't know where they came from either, but there's those two theories.
Yeah, that's important. So it brings us right into the discussion about the pandemic. And let me just get it clear. Prior to the pandemic, were you a rebel of any form?
No, so Philip, you say that as if I am one now. I don't think I am a rebel at all. I've never been a rebel. I was a very, very compliant person, very happy to have a quiet life. I was head girl at school. I'm not a rule breaker, and it's sort of, I'm not a rebel. I don't think I would categorize myself as that at all.
And so therefore, when the pandemic hit, I usually like to understand where people were thinking. Were you scared?
Yes. Not scared? I wasn't scared for myself for very long. I was to start with. And then when the Diamond Princess data came through, I stopped being scared for myself. But I was still scared about the NHS would get overwhelmed. I was still scared for my mum and dad. I was still scared.
When did that change? You said which data?
The Diamond Princess.
Okay, yes, so the Diamond Princess, the cruise ship. So when you saw that, what made you less fearful with that data?
Well, so this was a situation where cruise ships are, petri dishes for diseases, right? You can't lock people down. Everybody catches anything because that's the nature of a cruise ship. And this was a cruise ship like most cruise ships, where a lot of the people on board were quite elderly and some of them quite frail. And the mortality rate was very, very low. So even in retrospect, after I think they followed them up for 4 months, and they included any death in that 4-month period as if it was a COVID death. Nobody's ever said, oh, this person died coincidentally. They were all COVID deaths for 4 months. And, the fact is that a lot of people, when they're on the last legs, go on cruises. That's what, the mortality rate after cruise is not nothing. And even then, it was only 2% of those who'd had symptoms, which I know you don't want to kill 2% of people. I'm not suggesting that. But this is compared with what we were being told the risk was to young people and healthy people, this was a totally different story.
And so quite early on, you thought that this was being overhyped.
You know what, actually, I think at the time, I didn't quite clock that. I thought, well, obviously I'm not at risk, but I was assuming that people who were in power were assuming the same. So this was right back in spring 2020. And I don't think, because of the novelty of it, everybody was complying without being personally frightened at the time. And that was such a prevalent thing that, if you remember, it was late 2020 when the behavioral scientists said, we need to increase the level of personal threat that people are feeling. I can't remember the exact wording, but they were suggesting that people weren't scared enough, and they were going to focus specifically on the people who didn't think they were at personal risk and target them with a fear campaign. And of course, those people are, people in their sort of 20s and 30s and 40s who were not at risk, and they were right to not feel a personal threat. And so they did that campaign, and it worked. And the result was people who were not at risk being terrified, wearing masks for years later, locking themselves away for a long time. There's a lot of people who didn't go into public for a long time afterwards. And of course, you didn't see that. You didn't see that they were refusing to re-enter the public domain because they were locked away. And that, there was this sort of COVID anxiety syndrome, which was worse in people in their 30s.
And do you think that this has done long-term post-traumatic stress disorder to a significant proportion of the younger population?
I don't want to extrapolate to long term, but I think, I suppose if 5 years is long term, maybe 5 years is, then yes, I think there are some people who will never recover from what happened. And that includes a whole fraction of the population who continue to be terrified of COVID. We get into these little bubbles, don't we? But there is still a bubble, mostly on Blue Sky now, not on Twitter, who are constantly sharing advice on how to filter the air and what kind of masks to wear and what the latest variant is. And, why is everyone else ignoring this? It's terrible. What can we do to wake them up? So that, there are people who are still as scared as ever. And, then their voices aren't being heard. So that will probably make them more extreme, because that's what happens.
And now, interesting, you mentioned that. I was just talking with Geert van den Bosch, and he is very concerned about a new variant. From a clinical point of view, I am one of those people who looks out for COVID symptoms prior to any unusual presentation. So meaning that if somebody comes in with just strange symptoms, I go searching to see whether or not they've been exposed to COVID. And I think we underestimate that this virus is, how do I say this without getting censored? Let me be careful how we say this. We still haven't identified where it has come from. Okay, there is some thought it's just the wet market, but it could be elsewhere. And if it is, are we underestimating how significant it can be in causing long-term illness?
So I take your point without wanting to express it either, and I think the thing that strikes me the most is that on paper there are aspects of this virus that look very nasty. You can sell it on paper and using the sequence as having all sorts of qualities that you would think could be, bad at a sort of molecular biology level. But the reality is that it's not what you could sell as a fairy tale of what it would look like. That's not how it behaves. And we have to kind of separate out the theory from reality. And in reality, it acted like respiratory viruses do, which is to say that the vast majority of the time it's confined to the respiratory tract. And yes, there are aspects of it that are slightly different. So like every virus will have ways of dampening down the immune response in order to help their replication. And this one does too. And it seems to be quite good at it, actually. So I think for like the first 10 days or so, you get an immune response to it, but it's not complete. So the T cells are not killing the cells off the way that they normally would because there's a sort of interferon suppression. So interferon is cytokine that directs the immune system and tells it all what to do. And it's suppressed win COVID until around 10 days, when it normally sort of finally gets overwhelmed by everything that's going on. So you get the interferon, and then all the T cells come along and they kill the lung cells all at once. And that causes a cytokine storm, and it can cause that sudden drop in oxygen levels that, you know, means that that's the point at which people end up in hospital. But for the vast majority of us, all it meant was it lasted a bit longer than an average cold, because, you know, that period of sort of the immune system was on delay. So it took a bit longer before we got over it. But that is the story for the vast majority of us, isn't it? It was a slightly longer cold. And yeah, that doesn't mean that there weren't people that were sicker, but then there are people who get sicker after flu as well. So the question has to be, how does it compare to what would have been? So, you know, do we actually have a good control group of people who've had flu and had problems consequent to that? And, you know, were there doctors who used to ask those questions when someone presented with something strange, to say, well, did you have a viral illness in the lead up to this? And then, unless we approach it in that way, I think we're not really being scientific about it. And it's very easy, because of everything that's gone on, to start to see it as being special and different, and to give it a sort of status that actually just increases the fear levels around it, because we're not being fair about it.
One of the interesting things, so my thought on that is that I've never had colleagues die. This killed colleagues. So I know this was different, and the presentation was very unusual from a clinical point of view. The other thing I was thinking about as you were saying that is the Denmark data. When Denmark did a comparison between influenza and COVID, 22 to 24, they had something like 3 times higher mortality with just a COVID infection. So, and it was interesting that in that data, the people didn't die of COVID, because at this point, you didn't really see severe COVID with Omicron and so on. They just died, meaning that 3 times more died post-COVID infection in a month than they did with influenza. So this is where it leads me back to that question about pathology and pathophysiology. We are flying blind at the moment because we don't fully understand what is it from a mechanistic point of view that would cause mortality from kidney, heart, you know, lots of other things 3 times higher than influenza.
So I'm not sure I definitely know the study you're talking about. So I'll talk about a variety of problems with studies that have tried to measure this. There's a lot of studies from 2020. So obviously that's not the study you're talking about. And in 2020, what would happen is people would compare people who had tested positive for COVID with the general population and say, well, how much sicker are they? How much more mortality do they have? And that was not a reasonable thing to do, because in 2020, the vast majority of people who did test positive in that spring wave were in hospital, because that's where you could get a test. So the control group should have been other people sick in hospital. And what does that mean? How do they compare? Because obviously anyone, if you're testing a hospitalized population against the general population, you're going to see differences. So there's a load of studies that fall into that camp that are inaccurate because of the failure to compare like with like. Then there's the problem of what happens when you're called COVID positive. So first of all, in the community, people who otherwise would have got antibiotics for a community-acquired pneumonia were not being given antibiotics. In fact, they were often not being given any medical care. They wouldn't have any kind of face-to-face care with a doctor unless they were sick enough to be hospitalized. They were highly dependent on the oximeters. You know, everybody was looking at the numbers and treating the numbers rather than the patient often. And then when you were in hospital, often even in hospital, people weren't being given antibiotics in a way they normally would have been. So the prescriptions were down again for that. And they were being given novel drugs like remdesivir, which, you know, you shouldn't, if you're giving people novel drugs, you have to sort of factor that into the kind of equation. And And, you know, at the beginning, there were people who were being ventilated too aggressively. And then we know that had a mortality rate attached to it. So there's all sorts of aspects of people's care that needs to be unpicked before deciding it was more dangerous. Now, I'm not somebody who says there's all these things and then says, therefore, it was nothing. You know, I think there was something. But I think that once you factor in all of these other elements, it's not as bad as people have said it was. And like the big story, of course, is what happened in care homes. Because in care homes, there was a huge proportion of the mortality rate were the care home population, and the disabled. Like the disabled made up a big proportion of deaths. And in reality, they were denied hospital care. They were denied medical care because there were do not resuscitate orders put on people. So at the same time as hospitals were saying, we're not going to admit anyone on the do not resuscitate order. And so if you deny medical care to a population who actually use medical care the most, you know, hospitals have a lot of people in who are otherwise in care homes. And if you remove those people from a hospital, then you're going to have a mortality wave. You are.
You've touched on something here that I don't know if it's in your book. I haven't read the book yet. You've just said something here that is probably one of the things that is going to come back and haunt the medical profession. And I remember the conversation I had with somebody afterwards, after this had happened, where patients weren't admitted because there was a perception that hospitals were going to be overwhelmed. Mm. And when they weren't overwhelmed, they didn't change tack to admit them and give them a chance. Mm. Is there any good justification for what was done in terms of that decision?
It's really difficult, isn't it? I mean, there was some hospitals which overnight decided to sort of empty the beds, and they put people who were, you know, in need of hospital care, because people who are in hospital are there because they're being diagnosed or they're being treated. They put them into hotel rooms if they couldn't go anywhere else, you know. So people who didn't have a care home place or didn't have a home to go back to, they put them into hotel rooms. And like that's an appalling thing to do. But the thing is, if that's on the cards, that you could overnight put people into hotel rooms, then you don't have to do it in advance of a problem. You can do it if the problem arises. And so I think that's the key, is that this was all these actions were taken before assessing what the problem was actually going to be.
You know, you did some, this is important discussions, and you took the stance, especially through HEART, which is health and safety.
We changed it recently. It's the Health Advocacy and Research Team.
Health Advocacy and Research Team. And you guys were challenging the political narratives quite vocally at the time. They were consistently trying to suppress what you said. How in the world did you get involved in that in the first place?
Okay, so going back to sort of what, you know, I was scared in 2020. So how did I come to be doing anything at all? So in the summertime, when the wave had passed and, you know, everything should have just been back to normal, and it was kind of getting back to normal. People were starting to see each other again and trying to have a normal life. I was noticing what was happening with the data. So there was this sort of trickle every day of COVID cases and COVID deaths, COVID cases and COVID deaths. And it was the same amount roughly each time. And I thought, this is bizarre. You know, the wave has clearly passed. There's clearly the sort of, you know, there's something going on here that's different to what went on before. And as a testing expert, you know, not every medical test is perfect. And so what we do to overcome that is we say to doctors, only do a test once you've had a good think about what it might be, and the test can confirm your thinking. But you don't go around testing people who are otherwise well or have other different symptoms. You know, you target your testing in order to have a useful answer. And where we do test people who are otherwise well, so like for cancer screening, if it's positive, we don't then say you've got cancer. We say, let's do a confirmatory test, because that's just a screening test. And here we had this situation where everybody going into a hospital was being tested. So that's a screening test. Everyone was being tested. And so there ought to have been a confirmatory test, because you can't just test everyone and say that's real. And so I was itching to kind of figure out if I could prove that this was not COVID. But it was summer holidays and I've got 4 children and I didn't have a chance to really do anything until they went back to school. And then I dug into the data and I figured out ways to show it. So what I was doing was saying what you are calling COVID now in the summer is different to what you call COVID in the spring. And you could do that by saying things like, in the spring, the deaths were 60% men. And in the summer, it had become 50-50. And in the spring, the people on intensive care were disproportionately from ethnic minorities. And in the summer, it was back to the sort of usual ratios. And in the spring, people would die. The people who did die died within quite a short time of the diagnosis. Whereas in the summer, they were hanging on for ages and then dying. And, well, that's not the same thing. That's just people who are dying, having been, randomly tested positive. So I thought, well, this is a problem, that we can't just pretend this is COVID or it's never going to go away. So I spoke to, I didn't want to do anything about it myself, but I was aware that Professor Carl Hennigan, who's the director of the Centre for Evidence-Based Medicine in Oxford, he and I were at medical school together. And we hadn't been in touch for 20 years. But I knew he was talking about testing. I've been reading what he was saying, and I thought, well, if I give this to him, he could say this too. And he said, well, thanks very much, Claire, but you're the expert with credentials in this area. It needs to come from you. You've got to put up a blog and put up a Twitter and put your head above the parapet and say this. It's important. So I thought, okay. So I sort of reluctantly did that, and shared, wrote a blog and shared it on Twitter, and he shared it. And then I came under attack as as it was happening to other people in the similar position. And I kind of stayed talking about it and about related things anyway at that point. And people were being dismissed as lone wolves and outliers. And I was in touch with some of the other people who were speaking out, but we were doing it independently in the public domain. And a man called Nerys Bernard contacted us all and said, actually, what, you should speak as a professional body, come together, be a professional body and speak publicly like that. And that will give you more authority and more protection. And so we did.
Just pausing you there a second. So when you started to do this and you started to be attacked, because as you said, you've always been following the rules, supporting everything. What made you continue?
Well, there was a sort of funny situation where there I was, in this new position. And I was conscious that I'd been a bit naive, but that having done this, I was sort of already sort of in that other group. I had been othered by the medical community, so I didn't feel like I had so much to lose. I also was no longer working for the NHS and I wasn't about to go and get a job in the NHS because I was wanting to work in AI diagnostics. So I thought, well, that puts me in a position that's quite unusual for most doctors in the country. Most doctors are dependent on their NHS careers and as such are silenced by it. That's true for lots of different things. So I was very aware that if I was in that position, I would be very reluctant to be speaking out. And I wasn't in that position. And so I kind of had this feeling of needing to be a bit brave about it because I had the freedom to speak in a way that other people didn't actually have that much freedom to do so. So I want to pause you on that point.
a lot of people don't understand this. Why is it that the doctors don't have the freedom to speak?
It's multi-layered, this. So one aspect of it is, you know, career stability, that anybody who starts to sort of deviate from, you know, if you're saying something critical, then you're sort of marked as being a danger to the profession, or a danger to the hospital's reputation, or a danger to your team, whatever it might be. As soon as you're saying anything critical, you're sort of outside the tent a bit. And so I think everyone's very conscious of that within medicine. And I think medicine generally, we're all quite compliant people. And so we're not necessarily confrontational, and we're not frank about problems. Everything's done very gently and slowly and carefully if you're trying to correct something, and often, you know, too slowly perhaps. So there is that culture generally within medicine. And then also in medicine, over time, we've become more and more specialized. And with the specialization has come a culture of, you must not question, let alone criticize, the experts. With, you know, if you're a specialist in kidneys and you're asking a heart specialist about your patient, and the heart specialist tells you X, Y, and Z, then it's X, Y, and Z. And I find that you know, really problematic, not least because I don't think that asking questions should ever really be a problem, because it's about everybody's education, isn't it? And it's also just about always understanding exactly where the boundaries of where the evidence is, and where actually there is uncertainty, because there is uncertainty in things, there just is. But there is a culture that you don't question other experts in their area of expertise, because that shows you off to be disrespectful. And so that becomes a real problem when you've got a topic that's broad.
So I want to pause you on that, because this is a very nuanced, and you're certainly dissecting it in a very good way. So I think it's important. When we reflect carefully, therefore, on where doctors have been and where they are now, because when they did a JAMA study, the trust in doctors fell by 30% between 2020 and 2024. And part of it was related to the fact that they effectively didn't have any stance. They didn't have a stance before when vaccines were being mandated. They didn't have a stance after when there's a change to, they just almost had no voice. How is that true, for one? And if it is true, what should they do?
I think that is only partly true. I think the doctors that got heard were the TV doctors. You know, they were TV doctors, but they did that whole kind of soundbite approach, didn't they? Where they dumbed everything down, made it all sound simple, made them sound like the heroes, and that did not do medicine or the public a good service. And of course, the doctors that didn't buy into the whole pharma narrative in its entirety, or even the ones that did, but, you know, felt that there were ethical breaches, or that they had patients who'd been left behind. You know, there was all sorts of opportunities to speak up, weren't there? Right through lockdown, well before any of the pharma stuff happened. There were lots and lots of things that went horribly wrong for patients who were in doctors' care. And doctors weren't saying anything about it, and are still not saying anything about it. And I don't know quite what we do about that. I think within the medical community, of course, there are people who are both extremes on this. You know, when I was describing the people who are sort of still incredibly anxious, I think there are definitely doctors within that community. So we've got both extremes within medicine. And then we've also got this sort of politicized element of everything that went on, which means that the institutions and the authorities are in line with government on all of it. And so the people, there is not open debate. There has been no open debate. And medicine itself has failed to have open debate leading up to this. So this is a cultural failure that's well embedded before any of this happened. And we had a situation where doctors get given top-down protocols about what to do without authors on and without a way of questioning it or criticizing it. They just come down from above.
I think that this now leads perfectly into that question about what happened when vaccine mandates were then brought in for healthcare professionals who had been frontline and therefore had faced the virus before. When you saw those things happening, because you had the luxury of being outside the system, what were you thinking?
So I would go back a little earlier. I'd go back to autumn 2020, before HART was even set up. And I was speaking frequently to Jonathan Engler, who's a doctor, and he's legally qualified, and he's an entrepreneur. And we could see in autumn 2020, before there was a single vaccine that had any evidence for it, that mandates were coming. It wasn't that we weren't prophets, but if you looked in the right places, there were government conversations about this happening. And we thought, well, this would be absolutely appalling. It's completely against all the sort of foundational principles of medical ethics. What do we do about it? And like we're doctors, we're not campaigners. We didn't know how you'd go about these things, but we thought, well, we could do an open letter. Let's do a letter. That was our strategy. And we thought, well, if we do that, we need to gather doctors' names on it. How do we do it? So we wrote the letter and we thought, well, let's just send it to the contacts we have personally, our closest medical friends, get them on board. And then when we're sending it to people we don't know so well, at least it will have a bit of momentum and it'll be easier to grow it. So we both did that. And neither of us could get a single friend to sign. And most of them just blanked us. One of my friends did reply and said, well, of course, that would be utterly unethical, but I couldn't possibly sign your letter. She was very supportive throughout the whole thing, but that was her position. And what struck me only afterwards was that means that all of those people, whether they were blanking us or refusing to sign, it was because they knew it was coming. It's because they also knew in their heart of hearts it was coming. Because if it wasn't happening, they'd write back and they say, oh, don't be stupid. This isn't going to happen. What's wrong with you? Or they would write back and say, well, of course I'll sign that because that's never going to happen. That's the response you'd have if you didn't think it was happening. But they all in their heart of hearts knew it was coming. And then when of course it did come, it came for the care workers. So the care workers, 40,000 care workers were sacked in autumn of 2021 because of this. And the doctors didn't do anything about it. And it was only when their jobs were on the line that the doctors did stand up and a few did start speaking about it. And largely what happened, of course, was people just silently refused as the pressure went up, and it was immense pressure. I remember at the time, my postman's wife was a nurse, and they needed her income. They absolutely needed her income. They couldn't really do without 1 month of it. And he and I would talk on the doorstep again and again and just kind of give each other, just keep in there, just hang in there. There are other people, you're not alone. And that thankfully, that wasn't bad advice in the end. But at the time, we didn't know whether or not it would be. We didn't know whether or not these people were going to get sacked in the end. Although there were hospitals where if that had happened, everything would have just fallen apart, which is, of course, is what did happen when 40,000 care home workers were sacked. They sacked them in the autumn of 2021. You get to a position where that means you cannot discharge people from hospitals. And if you can't discharge people from hospitals, that means A&E gets filled up, which is what happened. And then the ambulances are stuck, unable to offload people. And there's an ambulance crisis where there's no ambulances on the road. That's what happened.
So here's a question. Should doctors have advocated for the care home workers who were then fired because of this?
Absolutely. Absolutely. Doctors have to, and they still have to, stand up for foundational medical ethics. There's not, no, there's a few foundational things that we have to stand by if we're going to have ethical medicine. First, do no harm as a precautionary principle. And then, bodily autonomy, informed consent, adults protect children, not the other way around. These are just basic fundamental principles. And if you just throw it away because of fear or because of your love of career, then what do you become? What is medicine without ethics? And it's not ethics, like medical ethics is not a subspecialty. It's part of every person's medical practice. Every doctor who practices medicine has to be doing so within an ethical framework. And our ethical framework is based in Christian values, which respect the dignity of the individual. The individual has their own dignity, and that's where the idea of bodily autonomy comes from. They decide what enters their skin. It's their body, not yours. And it's certainly not the government's. But we appeared to be in this strange theocracy that was based on utilitarian principles of the greater good. And the thing about the greater good phrase is it's sort of seductive. People seem to fall for it very easily. But of course, inherent in the phrase greater good is sacrifice. There has to be a minority being sacrificed for there to be a greater good. And so suddenly we were in a culture of sacrifice and nobody was calling it out for what it was.
Those are some powerful words, Claire. I've got to capture that bit that you've said. And you're right. You're so right. And it is worrying now that when we think about medicine, UK, this is across the world, seems to have shifted away from patient advocacy. And I don't know when that happened, but it seems to now be entrenched. And I don't know how this can be changed.
Those are difficult questions. I don't know the answers to them either. I think some of it, perhaps in hospital medicine, comes from people being, they used to have much more continuity of care than we have now. Doctors are sort of used as a sort of resource that can fill in gaps rather than being a doctor that will be looking after the same patients over a longer period of time. And in GP practice, there's just intense pressure, isn't there, to churn through your workload. And there's also this sort of huge problem of people's time that, people have been very ready to fill up doctors' time. So as well as face-to-face patient care, there's all sorts of other demands on doctors' time that does not leave a lot of room for reading the evidence and absorbing it and debating it. That just doesn't feature in how people think doctors should use their time. But also in advocating for their patients. If you're absolutely run ragged trying to just do the basics, that doesn't leave you time to be advocating.
This is some pretty serious stuff. I'm glad we've focused on it, because you notice that we haven't even really gone in any great depth with regards to what happened after 2021 and the consequences of that. And I think it's important for us to touch on that at least. Where do you stand? And I know the perspective certainly from Heart and the publications, but you would have known that you are going up against one of the most powerful industries if you were going to challenge what was happening at that time. What were you guys thinking?
Yeah, actually, you're really taking me back. So at the time, first of all, I thought the vaccines would work. So going back to early 2021, I was not an anti-vaxxer. I thought the vaccines would work, and I thought that what would happen is the government would say, we saved you with lockdown, and then we saved you with this product, and now we're the heroes. And I was really annoyed about that. I remember being very annoyed that that's what they were going to do. So I wasn't skeptical particularly about them not working. And it was only as the evidence came through, we started to see, first of all, waves of COVID with every different country that was starting to do the rollout, and the headlines would repeat the same thing again and again. You know, wave of COVID in the United Arab Emirates despite vaccinations. It was despite vaccinations every time. So we were just reporting on what we were seeing, and we were very cautious about how we did so, because we were very aware of what would happen to us if we got anything wrong, or said anything beyond what the evidence was showing. So we were very, very careful. And I remember at the time feeling like we were getting into more and more dangerous territory. And I definitely had, I was going to call it paranoia, but you know, it's not paranoid if they really are after you. I don't know if it's paranoia because I don't know if they were. I know in retrospect that the government had me on lists, but I don't know about the pharmaceutical industry, and I don't know where I stand with them now either. But there is, yeah, that, you know, we are up against powerful people, and it is quite sobering at times, and you do wonder whether that's wise. But I can't not say this stuff. I know that sounds ridiculous, but I would not sleep at night if I wasn't saying this stuff, because it's important, and I care more about, you know, the impact on the public and the fact the public aren't being told the truth. I think the truth really, really matters. And I want my children to grow up in a world where it can still be spoken. And that only happens if we speak it.
I remember thinking about, certainly I think before the rollout happened in a major way, my concern was primarily that I knew that this virus was so good at suppressing interferon. I knew that mucosal immunity was absolutely critical. And I didn't see how an injectable vaccine was going to train the mucosal system. So I was always kind of, well, let's hope and see. But I thought that the target would have been the high risk anyway, for which if you can do anything to try and mitigate their risk, then, you know, it may be worth it. But I remember being absolutely frightened when it was being rolled out to lower and lower age groups. And I then remember that conversation with Dr. Ross Jones. And this was before the decision to roll it out to children. And nobody thought that was a good idea at that time. And she was literally at her wit's end saying, you cannot do that. What were you thinking as this started to evolve?
So that was another horrible situation where we could see it coming. You know, they did start talking about children very early on, and just, you know, there was in public, there's sort of in Parliament, you know, Matt Hancock said it's an adult vaccine only for that adult population, and there was all these sort of things said that meant that if you suggested it, they were heading for the children, people would call you a conspiracy theorist in early 2021. But alongside all of this, there was this whole strategy written out about how they were going to vaccinate the children. So, you know, we weren't making it up. It was based in what they were planning to do all along. And then sure enough, it just got younger and younger and younger and younger. I mean, they went right down to 6-month-old babies. It was quite like astonishing. Having started saying over 50-year-olds, that was the starting position, that no one under 50 needed it. And then they end up with 6-month-old babies. It was really horrible. And we campaigned very hard around the children being vaccinated, because it was so clearly wrong that anybody, even pro-vaccine people, should have been able to get behind that. There was no reason not to get behind that. And of course, it allows you to make all the points anyway, because the points are valid regardless of how old you are. Although obviously the benefit lie changes massively depending on how old you are, because if children are not dying anyway, then they don't need it, do they? And the fact it didn't work for anyone means that, you know, that equation is not really the point. But there was never a case that there was an emergency for children and they needed an emergency medical product to stop them dying. That was not reality at all.
And so one of the things that still comes up, so therefore I'll ask you this question. I hope they don't censor it based on just this answer. Are you saying that you don't think, based on the research that you have looked at, that there was any benefit, not even to the high risk, in terms of reducing the severity of disease? What is your analysis on that?
So the starting point I would say is, with the test and trace system, Public Health England measured how many people in a household would catch it if somebody came back with it. If it arrived in a household, what percentage caught it? And it was around 8.5% in every wave, and it didn't change before and after the vaccines. The number of people who got antibodies to it was around 6% with every wave, and it didn't change with the vaccine. So, there was absolutely no question that it did nothing in terms of infection. So in terms of severe disease and death, there's this interesting problem where with every single wave, you get a few countries that are outliers that just doesn't seem to affect them for that particular wave randomly. And the UK, Portugal, and Ireland were outliers in the sort of summer, autumn of 2021. And I don't think that was because of the vaccine, because you can't have a vaccine that works in one place and doesn't work somewhere else. So if you look at Europe as a whole, if you look at the USA as a whole, the wave of mortality in that sort of autumn 2021 period was the same magnitude as the waves of mortality that came before. The number of claimed cases behind it was higher. So they could say, well, the case fatality rate has got lower. But the number of claimed cases was based entirely on PCR testing, which was just massively exaggerating the result. And as I said, if you measured it in terms of the percentage of households who were susceptible, that didn't change. And the number who got antibodies didn't change. So if you've got the same number of deaths and the reasonable measure of cases is the same, then nothing changed, did it?
One of the things that I thought about, and I don't completely disagree, I think that what seemed to happen is that the severe presentations seemed to decrease. What I kept on saying, though, is that I wasn't necessarily convinced that all-cause mortality changed. So meaning that, yeah, so someone didn't have severe disease, so they didn't end up on intensive care. But if they still died 2 or 3 months later, was that enough to warrant broad use, especially in the non-high risk? So there are lots of questions that were around it. And the other thing that I think you touched on that is important is that if this was correct, I would expect that in countries that had low uptake, they should at least have significantly worse mortality, no matter what their demographics were. Yep. And so people discount Papua New Guinea, 4.5%, discount Haiti, 2.7%. I don't think you should or can discount them without doing proper epidemiological studies to look at why and how they managed to evade that. So we are in a very strange situation now where the science does seem to be largely captured in terms of the outcomes. I don't know if that can be changed. If you go out there in the population, I don't know if from a scientific peer-reviewed point of view, you will ever find anything that's strong enough to support any other view.
So I'll take up all your points. First of all, the epidemiology thing, the key is there is no example of a low vaccinated population that did badly globally. That's the key. There isn't. Where is the example of it all going wrong? It didn't happen. And then your point about you perceiving that there were fewer people, I think that's absolutely true. And I think what happened is with vaccines, these vaccines and others actually, but these particular vaccines caused a period of immune. But basically what happens is, your body's making foreign spike protein in the cells because that's what the vaccine was designed to do. And your immune system goes and it deals with it. But that's kind of actually, it's quite busy dealing with it. The pharmaceutical companies published results showing that white blood cells circulating plummet in the sort of first few days after the injection. So you've got a period of where the immune system's not doing its day job. And so you're more susceptible to an infection. So if you've got that sort of 8% of people who are susceptible in a wave, and at some point during that period, they go through this period of immune suppression, then they get their infections earlier. And they get it in that 2-week period after the injection. And they end up in hospital, which is why we had the very, very severe spike during the rollout in January 2021. And some of them will die. And then you'll have this period after that where the unvaccinated are still doing a normal curve, but the vaccinated have this very steep peak and then nothing, because after that, you've either had it or you weren't susceptible. So you do get a period of time where it looks like it worked. And that's what all the studies were looked at, was that period of time afterwards. You're like, well, yeah, it does look like it worked, but that's not working if all you've done is make the cases earlier, is it? It's just it's actually what that's doing is overwhelming the NHS, because you're making it all happen at once. And so that happens with every dose.
Those are some very, very challenging points, Claire. You're sticking your neck out on that one, because at the moment, it seems as though there is the intention that the history will show that in the pandemic, everything worked fine. This is why we're out of the pandemic. 20 years down the line, children will be taught that all of the interventions worked, they were beneficial, they were protected. That's what history is going to show. Are you going to give them that? Are you going to allow them to say that?
I will try not to let them do that. But I'm not the only one trying, though. I don't think you're right about that. I don't think you're right. I think what will happen is what we've seen with every medical scandal. It takes 20 years for a medical scandal to be talked about openly. And I think that's what, it's quite funny, actually, from the beginning in 2020, I remember those conversations I'd be having with the various people who were speaking out, where we were on the one hand saying, well, where are all the other people? We need to find them. And then the other conversation we'd have repeatedly would be 2 more weeks. So I don't know if you remember back to summer 2020, when people would be on the beach and they'd say, look at these people on the beach, they're going to spread COVID. Just wait 2 weeks and we'll show you. And so we used to have this 2 more weeks joke. And our 2 more weeks was, we're going to, we've found this new thing. This is going to break it open. Everyone's going to realize, because we can prove this. And we're like, yeah, 2 more weeks, they'll all realize. And then it became, 2 more months. And then actually this is going to be a year, isn't it? And then this is going to be like a war. This is going to take 4 or 5 years. And of course, that's where we are now. And now we're like, actually, it's a 20-year game. I don't know if this is just going to keep going exponentially, but that's the journey I've been on.
So listen, as we're coming, this has been a great conversation, and we're coming towards the end. There's so many things we could have spoken about, but when we think about where we are now, and where things are going to go, because you sound as though you've been pretty accurate with predicting all of the steps that were happening. What do you think is going to be happening next? And then what I want you to finish off on is, I want you to speak to the medical fraternity about where they should be for that future.
Okay. So the first thing that's happening next is digital ID, and it's coming in globally, and it's coming in as part of a kind of United Nations plan. And as soon as it's in, the government, and it's not something that you can opt out of. It's not you applying for one. The government has a centralized database in which it will have your identity connected to your health records, your, crime records, whatever it is that they're tagged you for speaking out, connected to your banking records. So your bank, what money you can access will be related to it, or your travel permissions. And so we have to stand up against that, because as soon as you've got a system like that, people can't speak anymore. Now, we're not in that system, so you can speak now. And unless you speak about medical ethical breaches, they will happen again. Because that's the whole point of having ethical red lines, is that they must never, ever be crossed. And particularly in an emergency, the reason we have human rights declarations and bioethical declarations written down is in the cold light of day, you know, in peacetime, is that in the heat of the moment, when people think that something's gone terribly wrong, they can reference them and say, no, this is not something we do. This is an ethical red line. But the ethical red lines got crossed. And having crossed them, we have to acknowledge that. We have to say that should never have happened, and it must never happen again. Because if you don't do that, it'll happen again in a heartbeat. And we are in a situation where there are plenty of people in the WHO and in other positions of power in public health who like to keep talking about next time. And there will be a next time, because we have a whole load of money being spent on virus hunting. So there is a hunt for the next novel virus. And of course, viruses, you know, the definition of novel is way too broad. And the definition of pandemic is way too broad, such that any seasonal flu could be called a pandemic, because the definition is simply that it spreads around the world. There's no criteria for it being particularly deadly. So that never has to be proved. You're just saying there's a new virus and people are catching it. And so at any point, the WHO can declare a pandemic, and it will be next time before you know it. And so before we get to that scenario, we have to have the medical profession stand up and say, these things went wrong. These things were unethical, and we are not going to do that again, even if we are scared.
Wow. And so this is where we are. And so one of the challenges is that we have now, and I usually say it because we're in a very strange AI transition where things are going to change rapidly, the future lies with the younger doctors who are coming through. And what they are being taught is to shut up and just do the work.
Yeah. And also, of course, any younger doctor who objected to being vaccinated themselves, i.e. they read and had critical thinking skills, have been sort of excluded from going through medical school and excluded from, you know, the rules around being vaccinated as a young doctor are very, very harsh everywhere. And so we've filtered out the thinkers.
Wow. So, wow, I tell you, you know, Claire, I mean, as I said, there are just so many things that I wish we could discuss some more, but we've gone over an hour already. Maybe we should have another conversation, and that one we'll just focus completely on autopsies and pathology and so on. But your candor, your clarity, your call for ethics, I think is absolutely critical. And at this point, you can forgive the scare and the fright in the early phase of the pandemic. But at this point, you're right. If the medical fraternity chooses to stay silent again, we will absolutely destroy the trust of the public.
Yes. And the thing is that the fight has been won. We've done that. The public understand that there were mistakes. You know, you're not going out on a limb speaking now.
Yeah. So we need the voices. Thank you very much, Claire. Thank you, everyone, for being with us. And we look forward to sharing with you further conversations in the near future. Claire, do you mind just waiting with me for the outro?